Well, good afternoon, everyone. Welcome to Breakout Session 3. Congratulations on finding the room. If you did that, you've survived the first challenge. So this session is NDARC and Collaboration Showcase, and we have 5 excellent presentations. I do want to begin by acknowledging the traditional owners of the land that we're meeting on, the Gadigal people, and pay my respects to elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander people. So before we get into the presentations, there's just a few housekeeping issues. First and foremost, all presentations have 15 minutes, but they should do their presentation in 12 minutes, and there's 3 minutes at the end for questions, so not long, but hopefully we'll be able to stick to that. There'll be handheld mics that will rove for people who want to ask questions. So if you want to ask a question, just put your hand up and Amy will take the mic around. There's more than 350 people who've registered for the symposium, but those people are online. This breakout session is not online, but it will be available after the event alongside the recordings of the other sessions. So it will be available to people who attend online, just not live. And also don't forget the poster presentations are on display. So take an opportunity to vote for the poster presentations during the break, which will be directly after this session. So let's begin with the first session. So can I ask David and Emily to maybe come up and join us here while I introduce you? So our first session is preventing and reducing harm for parents and children through a family-based residential rehab service in New South Wales. Our first presenter is Dr. Emily Deans, and Dr. Emily Deans has worked within the gambling and other drug fields for the last 7 years. Emily's experience lies within qualitative inquiry, and her research focus is on understanding the environmental and structural influences on risk decisions and health behaviours. And she is passionate about using research as a medium to advocate for the needs of client groups. And the second presenter in this session is David Kelly, and David is the Executive Director of Programs at Odyssey House and an adjunct lecturer at NDARC. And David's worked in the AOD sector for more than 22 years across a range of treatment and support services, including working with Aboriginal community-controlled organisations. David's got a strong background in supporting partnerships between research and practice to improve outcomes for those improving services. So I will hand over to David and Emily, and I will make just a little noise at 10 minutes, so you know you've only got 2 minutes after that. Thanks very much, and thanks everyone for attending.
Thank you, Carmel. So as Carmel said, my name's David Kelly, and this is Emily, and we wanted to also acknowledge the other authors of the evaluation that we did onto the Odyssey Family Recovery Centre, including Sarah, who's here, but Winifred and Stella as well. And we also wanted to acknowledge traditional owners of the land that we're meeting on here today. So this may seem like a silly question. Why does supporting families matter? Why does supporting families around AOD issues matter? And obviously not all parents who use substances have problematic parenting. We know, of course, that's not true. Lots of parents use substances. However, when there is really problematic substance use, it can impact on parenting. It can impact on issues like abuse and neglect. It can particularly impact on things like attachment, which is a really key, function for childhood development. Parental substance use can be a key issue for neglect and abuse of children. I thought I was scrolling down there. And so Odyssey House's Family Recovery Centre has been in place for almost 50 years. We've been having children come into our residential treatment centre for almost 50 years because we recognise not just that parental substance use can cause harm for those parents' children, but also that even if there isn't harm to the parents' children, there's parents who need drug and alcohol treatment who couldn't go into treatment if they couldn't take their children with them. So there's obviously those two purposes for having a residential treatment centre where children can come. So the Odyssey Treatment Centre takes men, women, non-binary and couples. So it's I think the only centre that's not a mums and bubs only program. And in 2022, we started building our new family recovery centre. Previously, we'd sort of treated children as a dependent of the adult who was coming into treatment. And in 2022, when we started building a new family recovery centre in 2023, when we opened it, we really sort of changed our model of care. So we started really working with the family as a unit. So the parent has their needs, the child has their needs, and the family unit also has their needs. And that became our model of care for the Family Recovery Centre, which really changed how we were doing things. We also expanded our capacity and developed, as you can see, this beautiful new centre. So one of the measures that Emily will talk about is called the NICFAS, the North Carolina Family Assessment Scale. It's really become a key, not just outcome measure, but not screening tool, but a start for a case management plan, because that tool really does look at the child's needs, the parent's needs, and the family need. I'll hand over to Emily.
Thank you. Thanks, David. Yeah, it was a privilege actually to be involved in this project, and NDARC were able to lead the evaluation. So the good news is we were using routinely collected data that Odyssey House was all over, and we sought to look at 4 evaluation or outcomes in particular. So you can see those on the screen. And we really wanted to assess the outcomes for clients and children over the first 26 months of the program. So we wanted to see improvements obviously in psychological distress, quality of life, severity of dependence, and as David was talking about before, family functioning. The evaluation time frame was between July 2022 and August 24. Okay. So I'll just step us through the client profile to start off with. Of those enrolled at the Family Recovery Centre during the evaluation time frame, and obviously that was between July 2022 and August 2024. So we had 28 parents and 30 children, and the average length of stay for those who had completed or left the program was 130 days for the adult cohort and 84 days for the children. So the demographic profile was quite young. I still consider 20 to 35 quite young. So that was about 85% of the cohort, and it was a large female cohort. So about 79% of the cohort were females and 21% were males. Of the 28 adults, 92% were unemployed, and yeah, most had about one child in their care, while a smaller proportion had 2 or 3 children in their care. You can see from the infographic, the primary drug of concern was amphetamines, followed by cannabis and alcohol. And in terms of cultural background, half of the clients identified as Aboriginal and or Torres Strait Islander, and 7% were from cold communities. And obviously the 43% were from non-Indigenous and non-cold backgrounds. In terms of mental illness diagnoses recorded during that initial assessments with clinicians, quite varied. So we had 18% experiencing mixed anxiety and depressive symptoms, another 18% diagnosed with PTSD, and 11% with schizophrenia, while 29% of clients reported no mental health diagnosis. All right, so what did we see? What did we find? So the results of the outcome measures, K10, obviously measuring psychological distress, and WHO quality of life, were evaluated across 4 time points from intake through to treatment phase 3, and obviously the severity of dependence, which looked at AOD. So you'll see from the graph the most favourable outcomes for adult clients, which remained stable across all of the time points, was a reduction in psychological distress, as indicated by the pink line. And you can also see from the graph that K10 scores, measured downward the whole treatment phase, with averages at program completion actually indicating low levels of psychological distress for clients. With regards to quality of life, scores trended upward for each treatment phase, which is awesome, indicates improvements in physical and psychological health for clients, social relationships and environmental factors, which are obviously conducive to good health and well-being. In terms of family outcomes, as indicated by the NICFAS, there was some, really good, meaningful improvements in family functioning. I'm going to talk about the 3 categories that have got the big red circle around them, because we saw some really good improvements in those 3 categories in particular. So self-sufficiency, I'll do that one first, encompasses things like family income, financial improvements, even like the capacity of the family to have good food and nutrition. Family safety also improved, so that's things like a reduction in family and domestic violence, abuse and neglect of children reductions, and environmental factors conducive for family functioning, which encompass things like safe and stable housing, reduced neighbourhood risks and positive learning environments for children. We always have to say small sample size, so pilot evaluation does obviously impact on the generalisability of the findings, and that these conclusions obviously may not represent the wider population who are eligible to receive the program, but we were really, really happy with the pilot evaluation. So I'll hand back to David to talk about next steps, where to now, and the implications.
Thank you. I haven't had a noise from Carmel. Yes, we're obviously doing okay. 3 more minutes. Okay, no pressure. So as Emily alluded to, we actually finished this study a little while ago now, and it was a fairly small initial cohort that we were looking at. So since we finished the study, the Family Recovery Centre has been refunded for another couple of years, so that's good news, partly because of this initial evaluation. So the first thing we're going to do is to continue the evaluation. So obviously we'll be able to increase the number of families that will be part of the evaluation. We want to put a bit more acceptability, experience measures and that sort of thing into to see if our change in program is really acceptable and appropriate for the families. As Emily said, a lot of our families are Aboriginal families. Right now as we stand here, 100% of our children are Aboriginal, not 100% of our parents, but 100% of our children are Aboriginal. We do have an Aboriginal specific program in Odyssey, but we just want to make sure that that's really being appropriately delivered for Aboriginal families in the Family Recovery Centre. So we'll keep ramping that up. And as always, particularly in NGO sector, we want to work out a way to do follow-up evaluation to make sure that the outcomes that Emily showed are actually sticking post-treatment. And as always, that's not resourced and difficult to do. But so those are the main things that we want to do to learn from this study and to continue it. So thank you very much, everybody. We've actually done that presentation once before in 12 minutes, so we've had practice.
We do have time for some questions, if there's any questions.
Please be friendly. But anyway,
I got a mic first. Thanks. Hi, thanks everyone. That was great.
for sure.
I was interested. I don't actually remember this when we did the analysis, but the rates of mental illness were quite high in the cohort, and then that actually was shown to reduce the rates of psychological distress. I just wondered if you could talk a little bit about that, particularly David, your experience of working with these clients, if that was expected for you or that was surprising, if that's what you see in other parts of your service as well. Thanks.
Yeah, and we did do another separate evaluation of the whole residential, or all of our services, including the residential service, looking at the interaction between psychological distress at intake and mental illness, and then the impact on the program on both of those things. I actually just anecdotally thought the rate of mental illness was low compared to what we feel like we're actually seeing, and a little bit of that is about data capture and what we consider a diagnosed mental illness, who said it, was it the GP, was it self-reported, and that sort of thing. So it's probably actually low. But I do think the psychosocial, I'm not sure if I'm getting the question right, but the psychosocial support delivered in the program, the living skills stuff, the self-efficacy, all of those, particularly non-clinical treatment parts, really dramatically improve the improve the psychological distress as well as the quality of life as well. Is that what you're asking? Yeah, cool. Thanks, Sarah.
I also had a question about the mental health. I was wondering if you knew how many people it was their first time actually getting a diagnosis coming into Odyssey House, if you knew of that, particularly with the schizophrenia staff.
No, like not. But anecdotally, I would say very low. I would say most of them had, because people don't end up in, sometimes they do, sorry, I should take that back. Lots of people don't end up in a relatively long-term, quite structured residential program with their kids. Usually they've had some contact with some other things before, including GPs and stuff. So usually, sometimes we get a better diagnosis or a more accurate diagnosis, or cut the 10 diagnoses this person's presenting with down to something that's a bit more accurate. But I wouldn't say it was very common that people, that was their first diagnosis.
We can probably have 2 more questions. I think there was someone up the back there.
Thank you. I just wanted you to talk a little bit about what the program looked like. Like, what were they doing during the day?
So just quickly, so the Family Recovery Centre sits within the broader residential rehab. So what we try and do is the children during the day go to mainstream whatever is appropriate to their age. They go to daycare if they're younger, including Aboriginal community controlled daycare if they're younger, or they go to primary school if they're older. We don't take children over 12. And so during the day, the parents are participating in the main program with everybody else, so to speak, and that's what to us is normal residential rehab stuff. So there's lots of life skills, there's education, and there's treatment groups and there's counselling. And then in the evenings or afternoons, the children come home and they're doing parenting things. So they're sort of supported to do homework and cook dinner and do baths and all of that sort of stuff. So it's sort of a combination of what a normal resi rehab looks like and a parenting program in the afternoons and the mornings. I'm very happy to talk to you more about it afterwards. I just don't want to get shot by whoever the next presenter is.
Thanks for a wonderful presentation. I was wondering what way you might use qualitative research to assess what components of the program the parents valued.
Absolutely. I think that's the missing piece. So for those who don't know me, I'm very big on qual. I'm very big on getting perspectives of those who have been through the program, and I think that's something that we had in our report as implications, that we really need to explore how the parents and the carers and the young people experience the program. So absolutely, the way we would do that, I'd love to be able to do some work with, participatory based sort of research that's very creative. Obviously, if you're thinking about young people and how you can collect data with that particular demographic, and then obviously the parents and carers and doing something in that space, whether it be through focus groups or interviews. Absolutely, yeah.
Thanks again to Emily. Thanks again to Emily and David. I think that was an amazing presentation. And of course, I'm not biased at all because I am the CEO of Odyssey House. Just have to disclose that interest. So our next presentation is on the Association of Mental Disorders on OAT Retention, a systematic review and meta-analysis. And we have Lucy Tran who's going to do the presentation. So Lucy joined NDARC in February 2018. She's currently working as a research officer. She's got a strong interest in mental health and drug and alcohol fields and has worked on a series of systematic reviews that investigated mortality associated with stimulant and opioid use, as well as reviews looking at various interventions for drug use and mental health conditions. So thank you, Lucy.
Good afternoon. Like Carmel said, my presentation is just about the association between mental disorders and OAT retention. Just before we start, just an acknowledgement of country. So I'd like to acknowledge the Gadigal people of the Eora Nation, of whose lands we are meeting on today, but also the Gadigal and Bidjigal people of which the lands the research took place on. And I'd like to pay my respects to the elders past and present, and extend this respect to any Aboriginal or Torres Strait Islander people in this room today. I'd also like to acknowledge my co-authors for all their assistance. So Rebecca McKeon, Brodie Clark, Christel, Shalini, Mark, Emma Zara, and Louisa Degenhart. Sorry. And just the declarations of our funding. But I'd also like to dedicate today's presentation to Dr. John W. Lewis. He was one of the two co-founders or co-founding chemists of buprenorphine, which is one of the treatments I'll be talking about today, and he has recently passed away. So I just wanted to acknowledge his presence within this field and what he's done for this field as well. So going on to my presentation. So what do we know about comorbid or co-occurring opioid use disorder and mental disorders? So we know that it's estimated that 40.5 million individuals are living with opioid use disorder, and that the prevalence of a mental disorder among this cohort is at least 6 times greater than the general population. And we know that comorbid substance use disorder and mental disorders are linked to increased symptom severity, social and functional impairment, suicidal ideation and attempts, and mortality risks. So knowing that these two disorders co-occurring leads to poorer outcomes within these individuals, wanted to explore more about, okay, what is happening within treatment settings. So the treatment research is a little bit mixed in that some studies will report that opioid use treatment and having a co-occurring psychiatric comorbidity will result in poorer outcomes. So greater days of opioid use or lower treatment adherence. But then you get other studies telling you that they actually have similar or better treatment outcomes. So it's really much a mixed bag, and I wanted to go into more about why are we getting this mixed bag. And one of the things that I thought might have been the case was about the medications themselves. So we know that opioid agonist treatment is the gold standard treatment for opioid use disorder, and there are 2 main types. You've got buprenorphine and methadone. However, they act in slightly different ways. So buprenorphine is a partial agonist, whereas methadone is a full agonist. So they work on the receptors within the brain slightly differently. And this difference then can lead to slightly different outcomes and also different clinical recommendations. So if you look at clinical recommendations for treatment, they report different things for the two, where the 2 medications should be used. However, also a lot of the literature out there at the moment has really reported on the 2 medications together. So they just combine buprenorphine and methadone. They don't really tease apart what's happening between the 2. And hence that led to my aim of how can we better understand how comorbid opioid use disorder and mental disorders impact retention in OAT by medication type. But I also then ended up looking at the individual mental disorders themselves. So to do this, I did a systematic review, looking at any papers published between 1980 and the 8th of January this year. And essentially, I was taking any samples of adults that had opioid dependence in any treatment setting. They had to look at buprenorphine or methadone, but could look at any form of either medications. And I guess just to preference that within my review, I did not look at adolescents or pregnant women. And we only looked at OAT for the purposes of maintenance, not for withdrawal management. So just those 2 caveats. So I did random effects risk ratios and looking at what was the risk, the cumulative risk of each of the mental disorders on each of the OAT type retentions. So I looked at mental disorder groupings, so mood disorders, anxiety disorders, psychotic disorders, and personality disorders, but also looking at the individual mental disorders within those groups, and then looking at retention at 1 month, 3 months, 6 months, 12 months, and 24 months. This is just a diagram looking at how many studies. So as you can see, well, maybe you can't see, but there's a lot of studies that were at the top end, and then it really trickled down right to the bottom, where it ended up being about 42 cohorts for each treatment type. So if we look at buprenorphine, so we had 26 cohorts looking at just over 130,000 individuals, and 20 of those cohorts were from the US, so very US based in this analysis. But if you look at when we're looking at buprenorphine versus no specific mental disorder, so what that means is that I compared any personality disorder versus no personality disorder and so forth. What we can see is that there's a real strong effect very much at 24 months for all three of those groupings, where we were seeing that having any of those mental disorders led to poorer retention in buprenorphine. But we can also see that for any mood disorder, that effect is really prevalent from 6 months. There was a lack of studies looking at 1 month, but of the studies that did, they were looking at any anxiety disorder, and we're seeing that there was no effect of the mental disorder on treatment retention. Some people might ask, but what about against any mental disorder? So if you didn't have a mental disorder at all, what would happen? And again, we're seeing that effect at 24 months. We're seeing the similar effect of any mood disorder is becoming quite prevalent at 6 months onwards, that it reduces retention. But some of the earlier months just becomes a little bit more mixed. When we're looking at 24-month retention, I then, at every time point, I looked at every mental disorder, but this was where we had the majority of the data. So we can see that apart from social anxiety and GAD, so generalized anxiety disorder, we are seeing that having an individual mental disorder was making retention more difficult, in that people were dropping out more at 24 months compared to people who didn't have any mental disorder at all. Methadone. So once we switched our focus to methadone, what we can see is that there seemed to be somewhat of a reversal. So everything, when you look at retention up to 24 months, we weren't seeing any significant difference between the retention rates among people with a mental disorder and those without that particular mental disorder. But if we look at 24 months, you can see that any personality disorder and any psychotic disorder ended up being a protective factor. So if you had one of those disorders, you were more likely to be in treatment at 24 months compared to people who didn't have that disorder. So quite different from the buprenorphine results in that instance. And then when we looked at any mental disorder as a comparator group, you still had that relationship appear. So everything before 24 months, we weren't seeing a significant difference, but at 24 months, we saw that protective factor of any personality disorder and any psychotic disorder. Yep. And I also did some sensitivity analysis, so looked at whether there were study level methodological differences that could be associated with these differences in risk ratios. So I looked at whether there was a association of the time frame associated with the mental disorder diagnosis, so whether it was a current diagnosis or a lifetime, who assessed and made the diagnosis, so whether it was taken from case records or a clinician on the study did it, whether there was a provision of any psychosocial intervention during treatment, and then whether or not the study themselves were quite inclusive or exclusive in their grouping of the mental disorder groupings. And couldn't find any strong evidence for any of those differences in methodological structures actually impacting on the pooled risk ratios that I received at the end. However, also noting I didn't have enough studies at all to really do any real meta-regressions. So I couldn't look at confounding, so just putting it out there. But yeah, so lack of studies. So we only had 40 across all of the mental disorders. So there wasn't really enough that I could say definitively, but there's a real area for further research. Yeah, most of the significant associations were at the diagnostic group levels. So I guess keeping in mind that we didn't have enough data to really be able to dig into the individual level as well. And that is all.
Amazing. Well done. Yeah, questions. Thanks, Lucy. That was a really fascinating presentation. Now, are there any questions? I've got time for a couple.
Thanks, Lucy. That was great. Wow, that table's amazing. Well done. It's a lot of it's a lot of systematic reviewing.
I looked at a lot of things.
It's a lot. I'm wondering, like, it's really interesting. I'm wondering if you've had a clinician look at it, or if there are any clinicians in the room who wanted to comment on what that effect might be about with the differences between the two treatments. Because I'd just be interested to hear a clinical perspective.
Yeah, I don't know. Michael?
I mean, there's two questions. One is the drug effect, is it the pharmacological effect? Two is it some other effect within the program? And it's hard to say, but it is actually quite interesting. There are differences in the drug. Buprenorphine is a partial agonist. So I think some of the sedative components of methadone are probably showing some effect. But that doesn't make sense from the personality. So why you're getting that difference in effect in personality disorder, I would argue is more likely to be some other effect around the treatment program than the actual specific drug effect. That would be my guess.
Yeah. And I guess just to note that with methadone, especially in the US, there's always a counselling component attached with it. So it could be that because they're offering that, there's some arguments of do you just get into that treatment seeking cycle of I'm already in treatment seeking, I'm just going to continue and continue. Yeah, but anecdotally, a lot of people.
I wondered whether it had to do with maybe how often people have contact with their OHE treatment provider. So methadone, maybe they're more often, and maybe there's a relationship that's built that encourages engagement in treatment and retention.
Yeah. Because I guess for people who aren't aware, methadone you take daily. You go in, you're seeing people, you're seeing someone. There's some human contact. With buprenorphine in the US, you sort of have that to a certain degree because a lot of it's office-based. But in Australia, you can get it more monthly. But sadly, we didn't have enough data to also look into whether long-acting buprenorphine was any different from your Suboxone. There just wasn't enough studies to tease apart that level. But
I think it's such a good program.
Yeah. If anyone wants to report the data.
Well done, Lucy. Well done. That was, really so interesting. Thank you. Okay, so our next presentation is Capacity for Change. How is capacity considered when preventing substance use and harm in communities? Now, we have actually 5 authors who've been involved with this piece of work, but only one is presenting. But I am going to acknowledge all 5 authors. So we've got Dr. Peter Gates, we've got Dr. Skye McPhie, we've got Dr. Emily Deans, who we've already heard from, Craig Martin, and also Dr. Sara Farnbach. And Sarah's going to be the one presenting. So I'll hand I've got to do Sarah's bio, sorry. I'm sure she is well known to you all, but nonetheless, so Sara is the program lead for the RISE team, which is Research, Innovate, Strengthen, Embed at NDARC. She's a passion for partnering with priority populations to enhance health and wellbeing through evidence-based health services tailored to local needs. Her research program is focused on preventing harm from alcohol and other drugs in rural and regional New South Wales. And in 2023, Dr. Farnbach was awarded the Early Career Award for Excellence in Research relative to career opportunities by the Australasian Professional Society on Alcohol and Other Drugs. An amazing achievement. So I'll hand over to Sara. Thank you.
Thank you, and thanks all for coming. First up, so I acknowledge we are meeting on the Gadigal lands today, and in particular, I welcome and show my respect to any First Nations people who are joining us today. Now, this recognition of community is particularly important for today's presentation because we're going to be talking about how communities can come together to work to affect on drug and alcohol harms. This project is part of a partnership that we've done with Alcohol and Drug Foundation, and so through the magic of technology, I'm going to try and co-present with some of our presenters from Melbourne who couldn't be here today. Okay, so why community action? So communities are recognised as an important part of national and international strategies to reduce harms from drugs and alcohol. This is because of a range of things to do with the change in focus from individuals to community-based efforts, and also the knowledge that communities can act to do things to reduce harms within their community space. We know that communities can act to affect on protective factors and risk factors around drug and alcohol harms, and this can be to do with the availability of drugs within particular environments, neighbourhood safety, social norms around use and also around risk and protective factors. And how communities actually come together to work in this space can be done in a range of ways, one of which is using community coalitions which come together to try to address local harms within their communities. So I am going to hand over now, hopefully with the technology working, to Craig, who's going to explain a little bit more of this background of what this looks like in practice.
During our presentation today, you'll hear a handful of key terms, including community coalition and community capacity. In case people aren't familiar with these, we'll quickly run through what they mean. Let's start off by looking at the term community coalition. Think of this as when community members and people from different sectors come together to address a common problem. Not all community coalitions operate in the same way, and they can vary in terms of how effectively they work together. This brings us to the next term which we need to clarify, and that is community capacity. This can be defined as the attributes that collectively reflect a coalition's ability. An example of a program centred on community coalition is the Alcohol and Drug Foundation's Local Drug Action Team program. The Local Drug Action Team program supports community coalitions, known as LDATs, to pick, tailor, run and evaluate evidence-informed activities that address local AOD risk and protective factors. We do this by providing LDATs with written resources, guides and tailored one-on-one support via relationship managers who are experienced in health promotion and community development. If we look at what makes up an LDAT, LDATs are community coalitions that have a lead organisation for governance purposes and at least 2 other community organisations as members. These can be schools, educational institutions, local government, health workers, police, community organisations or businesses, to name a few.
We know that prevention programs led by community coalitions can improve health outcomes. However, the success of these programs can in part depend on the community coalition's capacity. If we revisit the definition of capacity from the previous slide, this makes sense. For example, if capacity is the attributes that collectively reflect a coalition's ability, it intuitively follows that high capacity or ability translates into more impactful and long-lasting programs of work. Within the context of the Local Drug Action Team, understanding each LDAT's capacity is also important for a few more practical reasons. The first is the program is big. There are over 270 LDATs across the country. And because of this, we want to be able to efficiently and effectively provide tailored and individualised support to each of these LDATs based on their current capacity. Coalition capacity is complex and multifaceted. In the LDAT program, we've noticed there are key factors that help LDATs to run successful activities and support the longevity of LDATs. These include strength of partnerships. So this involves having long-term members with extensive experience of working together. There's also leadership capacity, and this involves having one member being fully funded to coordinate the LDAT and their activities. Next up is alignment, and this refers to the LDAT's goals being embedded in the objectives of the member organisations. There's also breadth, and this is when the LDAT activity is being delivered as part of a comprehensive AOD prevention program. And lastly, engagement, and this involves the LDAT having a strong understanding of local needs, values and priorities through undertaking comprehensive community consultations. In addition to being multifaceted, coalition capacity is complex because it changes. It is not a set variable that can just be considered once. It can go up and it can go down, and that can happen quite quickly. For example, something can happen such as the lead organisation changing, and depending on who the new lead is, this can either boost or reduce a coalition's capacity. So we've covered what coalition capacity is, what influences it, and why it's important to know a coalition's capacity, and now we need to turn to how we measure it. Coalition capacity is generally measured by examining each of the factors that contribute to it. Measuring each of these factors can take a bit of work, so we need to make sure the methods we use aren't overly burdensome to complete from an administrative perspective. They provide relevant and useful information and are perceived as a valuable exercise.
During our presentation.
Okay, thanks. So as Skye's just nicely set up for me, we can see that this idea of actually looking at community groups or community coalitions to assess their capacity is an important part before they get started. But what we don't know, or what is less clear, is how we actually go about establishing or assessing capacity. So we set up this study with the aim of talking to people who are actually involved in coalitions. So these are program workers who are implementing them, and also people who make up coalitions, around what characteristics they think are important to assess, how to actually go about doing these assessments, and also how this information can be used. So as part of this project, we went to the literature because we love a framework, and we found this very complicated thing on the left here that I won't ask you to read in detail. But basically, the idea here was just to see what's been established as important when it comes to assessing capacity of coalitions. And what we did is we spoke to about 25 people who are working in coalitions currently, and we did qualitative interviews, and we coded inductively and deductively, which means from the bottom and also from the top, to work out what they thought was important. And I think this is the real point of difference of this research, is the previous research that we found when we were setting the project up has not done much in detail with people who are actually working in coalitions on a day-to-day basis. So just to give you a brief overview of the framework that we use, so this was that big long thing on the left a moment ago. These are the 10 key headings or domains that coalition capacity falls under. And what we can see here in green is the level of agreement between the original framework and then also what we found when we spoke to our participants in the study. So you can see there was quite a lot of agreement. A lot of what we found in the literature was also seen as being important to our participants, which is really great. And here in pink, we can see where there were new ideas that were identified by people who took part in our study that weren't in the original framework. So I'm going to talk very briefly about what these are now. So there was 3 key things under member characteristics that wasn't currently being picked up in the framework. The first is around assessing the extent of which a community coalition has engagement or representation from a lived experience representative on the committee. I mean, I'm speaking to the converted here, but this is something that's obviously grown in recognition in our sector in recent years, but that hasn't quite come through in the literature just yet. The other important point was this idea of including people in coalitions who are quite senior within their organisation, so they can commit resources, time, money, that sort of thing, to actually getting things done within their communities. Finally, under this domain was this idea of having alignment between the objectives of the coalition and that of the organisation that was taking part. Okay, thanks. And so this can be around a range of things, but mostly around just being on the same page around ideas to do with harm minimisation and these types of things. Finally, this idea of planning for sustainability. So planning beyond short-term one-off activities to longer than 12-month activities was also seen as being really important to our participants. What we found was that when these assessments are completed, coalitions are in fact using this information to inform planning, as well as resource monitoring, identify risks and gaps, and that was valued. So people are actually using this information as part of planning community work. And when it comes to how these assessments should be done, our participants told us that it should involve all members, so it shouldn't be some sort of abstract external exercise, but should be done with the coalitions. Should be done regularly, so a couple of times a year at least, and it should be solutions focused. So go beyond identifying gaps, but also propose what coalitions can do to address these. My final slide, so if there's a couple of things I wanted you to take away from today's talk, is that when we talk to people who are involved in community groups, they find that assessments of their capacity as a coalition is useful and valued, that there are new criteria that should be included during assessments. So these are around sustainability, lived experience, including senior representation and alignment of objectives. And that when these assessments are done, all coalition members should be involved, should be done regularly, and it also should be solutions focused. I'm going to leave it there. Thank you.
Well done, Sarah. That was great. So we do have time for a couple of questions. Are there any questions of Sarah?
Hi Sarah, thanks so much for your presentation. Bonnie Ross from Boxer, Bureau of Crime Stats and Research. My question touches on a couple of points you raised from the LDAC part of it, and then at the very end with your interview findings about, so important factors, partnerships was one of them in relation to LDACs, and then planning for sustainability. just thinking about some of the hurdles I've seen in my own work, staffing turnover kind of impacts both those points in a way. From this body of work, do you think there are any particular factors that could potentially help to sort of counter the negative effects of staffing turnover?
Yeah, it's a great point. I mean, this is the problem we were talking about it this morning in the panel as well, around there's not a heap of funding that goes into this prevention space, and a lot of it's more upstream. And you really see it at this pointy end of people working in community prevention, as I'm sure you're aware as well. How to overcome that, I'm not sure. It's about trying to get everybody on the same page and try and provide some way of some sustainable plan. As for the answers to that, I don't know. It's a complex space. I think there are certainly key organisations that show leadership within communities, and trying to find ways to partner with them so that there's ongoing support that you can leverage over the long term, and it's not just hinged on individuals taking part, is probably the best answer I can give. Pete, do you have anything to add?
I was just going to say planning for sustainability.
Yeah, it's a key thing.
It's also interesting how much of capacity is not just straight up money.
Yeah. Yeah. Yep.
I guess, Sarah, sorry, I guess my question again comes back to the funding, because I guess being a long-term supporter and involved in those things and going to now manage a drug and alcohol service, I guess it's disappointing from my end that there's no funding, because we're activity-based funded, when I have an array of amazing staff who could contribute to that, but under activity-based funding, it actually prevents health actually being actively around the table on all of those, when we should be a key partner. And I guess I've seen the funding space also for neighbourhood centres and other things also change, that I think has impacted significantly on key partnerships around a coalition. So I guess that's not really a question, but
yeah, it's a nice point though.
Comment.
Yeah, thanks, Di. Yeah, excellent, thank you.
Thank you so much, Sarah. So we're now on to our fourth presentation. So there's two more. So the fourth presentation is by Dr. Christel Macdonald, and it's Are methamphetamine users at increased risk of physical violence? Results from a nationally representative sample. And Dr. Christel Macdonald is a postdoctoral research fellow at NDARC. She completed her PhD in March 2024. Her thesis explores factors related to court diversions for offenders with a mental illness or cognitive impairment. Christel has worked in research in the drug and alcohol space at NDARC since 2019, with a particular focus on treatment and intervention for people coming into contact with the criminal justice system. Thanks, Christel.
Thank you for that introduction, Carmel. So yes, I will be speaking today about a paper I worked on with Rebecca and Don, looking at individuals' methamphetamine use and how it might increase their risk of physical violence. So globally, the use of methamphetamine has increased since 2010, with latest estimates putting the number of users at about 30 million worldwide. And it has been shown in literature that it is associated with an increased risk of violent behaviour, but it's also kind of a common thought of the media. It's always saying, you know, methamphetamine makes people violent. But what about violence victimization? It's just as important for this subpopulation. There have been some studies. So Kramer et al. Interviewed individuals, about 700 from rural communities within the US, and they found that women were more at risk of physical violence from a partner in the previous year if they were aged between 23 and 41 years old, and if they were dependent on either methamphetamine, cocaine, or alcohol. And men were at risk for being a victim of non-partner violence if they were younger than 23 and they were cocaine dependent. They didn't find an effect on methamphetamine amongst men. Watt et al. Interviewed individuals from South Africa, and they found a significant relationship between the severity of methamphetamine dependence and being a victim of intimate partner violence, but interestingly not perpetration. Although these studies do provide some insights, they did use quite small and unrepresentative samples, and they also only interviewed people who had either a methamphetamine dependence or a stimulant dependence. So they had no comparison group of non-users. Foulds et al., however, did do a study of over 1,000 individuals in New Zealand, and they found that those who use methamphetamine at least weekly between the ages of 18 and 35 were significantly more likely to experience violence than those who never use methamphetamine. And importantly, this is while controlling for things like gender and previous experiences of abuse. However, there haven't really been any Australian studies using large samples, so the aim of my study was to fill this knowledge gap. In doing so, though, it is important to consider what else the literature says is associated with violence victimisation. And most research within Australia has focused on women and women's experiences of violence, finding that financial stress, personal stress, alcohol use, social isolation, and long-term health conditions are all associated with increased risks of violence among women. So for the current study, I wanted to use a data source that had information on methamphetamine use, but also those variables I just spoke about, which brings me to HILDA, which is the Household Income and Labour Dynamics in Australia survey. It's been going since about the year 2000, I think, and is longitudinal, so the same people are surveyed in each wave, and importantly, new people are also added in each wave. Because surveys are expensive and researchers have lots of questions they want to ask people, they don't ask about the same questions in every wave. So unfortunately, methamphetamine use has only been asked about in 2017 and 2021, so they were the two waves that I could use. So amongst those two waves, there was over 18,000 individuals across 31,000 records. And I'm sorry, I'm going to get a bit statsy in this presentation, but I use generalized estimating equations, which basically allow you to account for the fact that responses are related. So in this case, the same people completed both waves in some instances. And the outcome of interest was whether people were reported being a victim of violence, specifically physical violence, for example, assault, in the past 12 months. And my main independent variable was methamphetamine use frequency, which is categorized into don't use every few months, and use once a month or more. The HILDA survey does have more categories than this, but because methamphetamine use was quite low in the sample, I had to collapse across categories. The covariates I looked at were age, gender, and area, so major city versus regional or remote, as well as those variables that I spoke about: financial and personal stress, long-term health conditions, social isolation, and alcohol and cocaine use. So just going to the descriptive stats, so 53% of the sample were women. The median age was 45. As I just alluded to, only a small proportion reported methamphetamine use in the past 12 months. And likewise, only a small proportion reported being a victim of violence in the past 12 months. So this is the GE analysis. Don't get too scared. I will break it down. So firstly, I did bivariate analyses, and then anything significant was entered into the model. And the only variables that weren't significant was survey year, and because we're interested in thinking how COVID might have impacted violence, so we added that to the model, but it wasn't significant, and neither was area. So I looked at men, women, and everyone together, but for the time's sake, I'm just going to go through men and women separately today. So starting off with women. So we did find an effect of methamphetamine use frequency. So women who reported using methamphetamine either every few months or once a month or more were significantly more likely to report being a victim of violence. And it is quite a strong effect. There were quite a high odds ratio, with women reporting once a month or more, near like 11 times. But just pointing out the confidence intervals are quite wide. We see that risk declines with age, so everyone compared to the 15 to 26-year-old age group has lower odds. But risky drinking being drinking more than 10 standard drinks a week. So women who were risky drinkers had twice the odds of reporting being a victim of violence. And financial stress there as well. Turning to the other covariates, so in line with past research, we find that women who were extremely socially isolated, who had a long-term health condition and personal stress, had higher odds of being a victim of violence. But very interestingly, women who use cocaine a lot had reduced odds. So I don't know what's up with that result, but it was interesting. Now turning on towards men. So men show a similar pattern to women with a few noteworthy differences. So like women, we do see the risk declining with age, so that age group there the 15 to 26 remains the strongest or the highest risk. But methamphetamine, we only see increased odds for men who reported using methamphetamine once a month or more, and it is a smaller odds ratio than the women. We don't see an impact of risky drinking, but we do see an impact of financial stress among men as well. And we also see the extremely isolated men with long-term health conditions and personal stress were significantly more likely to report being a victim of violence, but we don't see that impact of cocaine. Now this is a predicted probability graph, and this is from the total sample. And so the top line there is women and the bottom line is men. The bars there are standard errors, they're not confidence intervals, so they are quite wide. So I can't make too firm of conclusions from those, but we can see for each methamphetamine frequency on the bottom there, women's risk are higher. So for example, women who were using once a month or more, their chance of being a victim of violence is about 7%, but it's only just over 1% for women who don't use. So we are seeing this impact of methamphetamine use among both groups, but particularly among women. Okay. And then this is plotting against age. So again, we are seeing that the youngest age group has the highest risk, but that using more methamphetamine across all those age groups increases your risk, so 11% versus 2% for that younger age group. So in conclusion, we did find a significant association between methamphetamine frequency and violence victimization in a nationally representative sample. And this was even while accounting for age, gender, stress, and long-term health conditions. And there does appear to be a dose-response relationship where the more meth that you use, the higher your odds. And importantly, along with past research, we found that financial stress, personal stress, social isolation, and long-term health conditions significantly associated with violence victimization, including among men, which I think is important to look at. Promise is my last slide. So we can't establish causation. That's important to acknowledge because the relationship might be cyclical between drug use and violence. And there's also the inherent risk of the illicit drug market that would be there regardless of the drug that you choose to use. There was a small percentage of people reporting being a victim of violence and meth use, which is the reason why those confidence intervals and the standard errors are quite large. And we couldn't explore fixed effects, which would be a better analysis type than a GEE, but you need people to vary in the outcome to look at that. And people tended to report the same thing from wave to wave, so we couldn't look at that. And finally, household surveys underestimate meth use prevalence because they don't sample enough people to begin with that use methamphetamine, and also among those that they do sample, they would underreport because of social desirability bias. I think the survey being self-complete would mitigate some of that bias, but it can't completely get rid of it. So, thank you.
Thank you. Another really interesting presentation. So much good work happening. Any questions? We've got time for probably 2 questions. Questions? Yep.
So I'm actually in the pediatric space. So looking at this kind of violence, was it just looking at the victims of violence for the individual who's the adult filling out the survey, or was it looking at family violence or
it was for the individual, but they do survey people under 18. I haven't looked at the age though. So you could see from the table there was 15 was the youngest, I think, but anything younger than that, no, it was about the person who is completing the survey. Yeah.
Okay. All right. Well, thank you again, Christel. Yeah, really very interesting. Okay, so now for our final presentation, which is working with multicultural communities to advance equity in alcohol and other drug service delivery, practice-based insights from Western and Southwestern Sydney. So there are 3 authors of this, but unfortunately Teguh Syahbahar cannot be with us today, so David is going to present on Teguh's behalf. The other 2 authors are Dr. Catherine Foley, who is here but not presenting, and also Dr. Nirekha de Silva, who will be presenting. So I won't introduce David again because I've already introduced him, but Dr. Nirekha de Silva is a research officer and counsellor at Odyssey House and adjunct lecturer at NDARC. Dr. De Silva has a PhD in healing cultures and a career spanning child protection, gender affairs and trauma-informed practice across South and Southeast Asia. She brings a deep expertise in culturally responsive AOD treatment. Dr. De Silva leads research and program evaluations to strengthen services for multicultural communities. Thank you. Thank you, Nirekha and David.
Good afternoon, everyone, and thank you for joining us. Our presentation today is titled Working with Multicultural Communities to Advance Equity in Alcohol and Other Drug Service Delivery. I would like to start the presentation with acknowledging the traditional custodians of the country where we live, work, and heal. We pay respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people here today. We will be sharing practice-based insights from Odyssey multicultural program which operates across Western and Southwestern Sydney. Our Executive Director David Kelly and I from Odyssey House will explore some of the challenges faced by culturally and linguistically diverse or CAL communities in accessing alcohol and other drug services and share some practical strategies and implications for research and policy. CAL communities often experience unique barriers when it comes to accessing AOD treatment. These include stigma, language difficulties, and cultural differences in how substance use and help seeking are understood. Despite policy commitments to equity and inclusion, many CAL populations remain underrepresented in treatment datasets and underserved by mainstream services. This gap not only limits access but also creates health inequities. So the question we are asking today is, how can AOD services move from good intentions to genuine equitable practice? Our insights come from Odyssey Multicultural Program, which has been operating for several years in Sydney's diverse communities. The program is rooted in practice-based evidence, meaning that we draw from real-life fieldwork and client engagement, not just theoretical models. By working closely with multicultural and multi-faith groups, we have been able to develop approaches that are more accessible, acceptable, and effective for people who might otherwise disengage from mainstream services. We would like to highlight 3 key strategies that have emerged from this work. First, we rely on informal partnerships with cultural brokers, community members who act as bridges between services and clients. This builds trust and credibility. Second, we use narrative-informed brief interventions where the focus is on listening to and respecting cultural meaning-making in client stories rather than imposing a purely clinical framework. And third, we integrate family and community networks into the support continuum. From many care clients, recovery is not just about the individual, but also strengthening family and community ties. These 3 strategies, working with cultural brokers, narrative-informed brief interventions, and integrating family and community networks, are at the heart of how we have been able to make services more accessible and relevant for CAL clients. At this point, I would like to hand over to our Executive Director at Odyssey House, David Kelly, who will share further reflections on how these practices-based strategies connect to broader organizational priorities and sectors' responsibility to advance equity in AOD service delivery.
Thanks, Dr. Nirekha. So, as Nirekha said, in multicultural programs, we've really been sort of operating, and it's a shame Michael left, we've really been operating sort of in a partnership between multicultural programs, really a service delivery organisation, NDARC that have been working with us right from the start of setting up multicultural programs to make sure there's been a research lens all the way through. But almost more importantly than both of those has been community engagement and genuine community collaboration and co-design. Right from the start of delivering multicultural programs, we've been engaged in community fora, engaging with all sorts of different community groups, particularly in Western and Southwestern Sydney, and then learning from what they were saying about what we needed in our programs and services, and then feeding back into our research and evaluation what they'd been saying. And I really want to acknowledge some of the staff from NDARC, and particularly Winifred and Stella as well, who aren't here today. And so some of the things that we have seen in our service delivery part of what I just said has just been improved treatment outcomes. So one of the things that we were finding when we first started the program and had the handover from DAMEC is things like shame and stigma, including from culturally and linguistically diverse groups themselves, from community leaders, other families, was preventing people from help seeking. Their primary source of help seeking often was to go to community and faith leaders, the stigma and discrimination and so on. So engaging with community leaders teaching us as well has led to an increase in help seeking and also a decrease in disengagement. I think it's not just in CAL communities, but all communities. Engaging with families, friends, carers and communities leads to improved treatment outcomes in treatment. And also just improving the cultural element of the service delivery. All the staff in Odyssey multicultural programs are members of their own community 100%, but still hearing from the outside community, not just the clinicians, has really improved that. And so as Nirekha was saying, it's led to us looking not just for ourselves, but we're trying to develop some things that are going to improve the service system generally. And we've absolutely found, and it's not, I don't think would be news to anyone in this room, that systemic marginalisation, in some cases racism, and lack of access to services is definitely an issue for people from CAL backgrounds help seeking. And also, which we'll get to in the next slide, but and somebody was talking about it this morning in one of the plenary sessions as well. The system in Australia, the system, we work mostly in New South Wales, isn't still necessarily fantastic at working and understanding the needs of CALD people and CALD communities that are coming to them from help. So that's one of the things that we've also learned. And so culturally responsive AOD practice, and I'll talk in the next slide, is required, not just for us, but for the system. So some of the implications from the ongoing research that we've been doing with NDARC, but also the ongoing interactions we're having with community. And this first one, we sort of say it every single time that we do a presentation around working with CAL communities, but we don't. CALD status is not part of the minimum data set or the national minimum data set. There's some stuff in there about country of birth and language you speak. But if we're looking at CALD status as being, for example, you or one or both of your parents being from a non-English speaking country overseas, country of birth and language spoken at home doesn't capture CALD status. So we actually don't know the proportion of people of CALD status that are seeking drug and alcohol treatment. We know a little bit from the household survey, because that does ask about CALD status, about drug use in CALD communities. We don't know very much at all about what's happening in treatment and prevention and early intervention. So absolutely disaggregating CALD status data can't do anything else until we know the basics. So that's the first thing. engaging more with the multilingual but culturally linguistically diverse peer workforce and staff is obviously vital, and I think has been one of the key strengths of the Odyssey multicultural program. And as I said earlier, and Dr. Nirekha said as well, and I think this is 1 minute, okay, it is a thing across the board, not just with CAL communities, but co-design with the people that you're researching. Like, I think hopefully everyone in this room would agree with that, but still research can be a thing that's done to people, not with people. So that is also a key thing that we've learned. And so I've addressed most of those. So thank you very much. All right. Obviously starting.
No, I still go at the same time. So we do have time for a couple of questions, if there are any questions. Thank you to David and Nirekha.
Thank you, Nirekha and David, for your presentation. This feels a bit like a silly question, but what characterises an informal partnership?
With whom?
With, I think, Nirekha, that was one of the points in your presentation about working with cultural brokers, about
Yes.
the importance of informal partnerships.
Yes,
And
we have cultural engagement activities that we do workshops with the different communities, and we also train the AOD champions. We also have religious and community leaders that we consult. We have meetings. We discuss about AOD issues with various religions and how we can support the religious community in treating AOD issues of their community.
Thanks, David and Nirekha. Lovely talk. I'm just muddling in my head. I'm listening to you talk about stigma and discrimination and how that's a barrier to access, and then also the diversity of the groups that you're talking about. And I'm just trying to work out how to make this a question. Like, I'm thinking about this tension between this big diverse group of people that we're talking about, and how you actually go about delivering care or creating models of care and providing services with a range of different needs, and whether it is about just reducing stigma and discrimination, or are there particular things that we need to do that are different within different communities, and how you actually go about doing that in practice in service delivery.
Yes.
Thanks.
Thank you. As I earlier said, we have different workshops with different communities. Like, we had workshops with Buddhist community separately, Islamic community separately, then Vietnamese community, Sinhalese community. Our community engagement officers and the research team work together so that we identify their issues, and then we try to work on programs that are for them.
Yeah, I think there's something that there's a lot of things that we did find were common. I found that I went to most of the engagement workshops, and I did with the North African Muslim community and the Asian Buddhist community, and there were some things that were actually quite surprisingly, maybe to me, common, and that they were things that we could then work on across the board. And then there's some things that are very different between different communities, how they help seek, how they see professionalism in clinical treatment and things like that that are quite different and then need to be addressed differently. Yeah, so it's tricky. Yeah.
Thank you. A great presentation. I work at the Southwest Local Health District. I was wondering, do you work collaboratively with the LHD, like through a health promotion programs or something like that?
We definitely work very collaboratively with Southwestern Sydney LHD, particularly with drug health, more so than with health promotion, and also a growing relationship with multicultural health in Southwestern Sydney LHD as well, and Western Sydney LHD as well. But we're very, very keen to, because we do a lot of community engagement work, health promotion work, and primary and secondary intervention, which we're really keen to work even more with the LHD.
Thank you. Okay, so that's the end of our formal presentations. Can I just put our hands together again for all the presenters? some really excellent work being done, and so good to see that collaboration between researchers and service providers that we saw in a number of the presentations. So thank you all. I think everyone got a lot out of that. It is now time for afternoon tea, so you can go to afternoon tea. I think we're going back at 2:50 in the main hall for the session 3. And again, just don't forget, if you want to vote for the posters, there's the QR code that's in the event handbook, or it's also listed alongside the posters. So thank you very much, everyone.